Welcome, and we'll go ahead and get started. I'm Jen Kovich-Bordnick with the Ehealth Initiative and Foundation in Washington, D.C., and so delighted to welcome you here today. We are talking about a very important subject about how providers are scaling virtual care, and we're going to share some amazing best practices. This is a topic that is of great interest to people across healthcare, whether or not you're a patient, a provider, a consumer, a vendor. I think, the year of 2020 and the pandemic has really just launched virtual care in a way we have never seen before. And there are so many questions about how to scale it, how to do it right, and what's going to happen after the pandemic. And we're going to get to all of that today. So thank you for joining us here today, and we're delighted you're here. I do want to let folks know we have a lot of time for Q&A today. So please go ahead and put your questions in the Q&A box there below. We're going to get to as many as we can today, but this is a great opportunity to reach out to Drew and Angie, who are just incredible experts in this area, and get their thoughts and feedback on what works and what doesn't work. So go ahead and send us your questions. So again, I'm Jen Kovich-Bordnick. I'm the CEO of the Ehealth Initiative and Foundation in Washington, and welcome. We've got two incredible speakers with us today. We have Angie Stevens, who's the founder of Virtual Insights, and Drew Schiller, who is the CEO of Valytic, and one of my favorite people to have on a webinar. And excited to get to them. After we go through each of their presentations, we're going to have a little bit of panel discussion, and then we'll open it up to questions from everyone. Let me go through a couple of quick housekeeping items while we're getting started here. So the next slide. For those of you who aren't familiar with the Ehealth Initiative, we are here in Washington, D.C. We are a small nonprofit, but a mighty nonprofit, very engaged in education, advocacy, and thought leadership, all around how we use technology and innovation to advance care. Next slide. And the wonderful thing we do is we get to work with companies from across the spectrum of healthcare. So if you're a payer, a provider, a vendor, a consultant, a lab, if you don't see your company's logo up there, it means that you're not engaged with us, and we want to work with you. So please feel free to send a note through the chat box to myself, and we would love to reach out and talk to you after this program today about how you can get involved in our education and thought leadership programs. It's an incredible group of executives that we get to work with, a wonderful network, and doing some really exciting things. So I really encourage you to get involved. Right now, we're working on 4 key issue areas, the eHealth Initiative. Consumer privacy for health data. We're doing an incredible grant right now with the Robert Wood Johnson Foundation, building a framework, which we will be launching next week. A lot of work around virtual care best practices. Today's just an example of the types of programs we're doing around virtual care, and a significant amount of work around SDOH, health disparities, and artificial intelligence. And hopefully you've been able to come to some of those programs as well. And everything, I think all of our worlds have really been impacted by the pandemic in the last year. So you'll see a lot of our programs really focused on COVID-19 and how these 3 areas intersect with COVID-19. This is just a sampling of some of our forums and webinars. And as I said, we are a nonprofit, so all of this is available to the general public free of charge if you go to our website, ehidc.org. And I want to encourage you to take a look at these reports, documents, former presentations, slide sets. You are welcome to share them, distribute them. We really want to serve as a resource to the industry and the private sector. So please feel free to jump in there and look at that. The other thing that our resource center does at ehidc.org is if you have something, a report, a program that you'd like to share, we encourage you to upload it. We are a free open forum, so please go ahead and share resources that you have on your deck that you feel comfortable sharing. And finally, this is a sampling of some of the publications that we put out in the last 12 months. A lot of really important work around COVID-19, supporting American Indian, Alaskan Natives, guiding principles for how to use social determinants of health, a lot of work around telehealth and reimbursement and how to get reimbursed for virtual care, and we'll be continuing to do that work throughout this year. And as I mentioned, we've got some really interesting stuff coming up. First of all, which I don't see on this list here, but I'm going to tell you anyway. On February 9th, we're releasing our consumer framework for privacy. And you will see a notification about that out later today if you didn't see it yesterday. On the 17th, we've got a great program looking at digital transformation with robotic process automation, which is really cool. I think you'll be excited about that program. A lot of interest in information blocking rules and the impact on HIE, which is coming on February 23rd. And we'll be looking at healthcare consumerism on the 24th. So please join us for those programs. And I want to thank Drew and Valytic because they are just incredible, a wonderful supporter of Ehealth Initiative, a friend of EHI, and have done great work since we first met them 5 years ago. Just an incredible organization and has always been pushing the envelope and doing exciting work in this area with remote patient monitoring and patient-generated health data. We've done an array of reports and educational programs with them, and just delighted to have them sponsoring this program today and supporting it.
Always a pleasure.
So glad to have you. And without further ado, I'm actually going to turn it over to Angie Stevens now, who's going to talk a little bit about what's happening with their work.
Thank you so much. I really appreciate being invited to this forum. I think this is so timely given the past year. I've been in healthcare IT my entire career, and I think looking back, one of the most pivotal times was when we started shifting to electronic medical records. And I never thought we would hit something like we did over the past 12 months, where we really accelerated the shift in the way we deliver care. And I was fortunate enough to be part of Kaiser Permanente during that time. So approximately 8 years or so ago, I joined KP as the enterprise lead for telehealth, and was able to work across all of the regions to implement a variety of solutions, one of which is remote patient monitoring, which we'll talk about today. So you can go ahead and go to the next slide. I don't think I have to go into this too much. I think everyone recognizes that chronic disease management in general is a significant challenge within the US, not just from a health perspective, but also obviously from a cost perspective. And everyone's looking at how do we manage this population in a very effective way. And that has some nuance to it, and we'll talk about that a little bit in the next few slides. But the other thing is that the market recognizes that this is an opportunity to provide solutions. And we're seeing the devices become a lot more sophisticated, capturing more and more data, and also just being lower cost, easily accessible, that sort of thing. So you'll see that this market in general continues to grow. And fortunately, one of the silver linings over the past year is the reimbursement of this has really changed. And so now we're looking at an opportunity to turn what was, kind of a burden into a revenue stream while still improving the quality of care that providers are delivering. Along with this is just kind of that natural shift into value-based care. So I know we're not there yet, but as we look at how do we manage populations from a keeping them healthy perspective for reimbursement, these are the types of tools that need to be in place to do that. So next slide. So again, I think one of the biggest challenges in this space is that it can be really overwhelming. There are so many devices out there, there's so many opportunities, and within an organization, there are likely a lot of different opinions on how do we attack this, what do we do, how do we make sure this is successful, are we really going to get a return on this investment, and it can become very overwhelming, and I think sometimes that's where things stop. So I want to talk a little bit about how, while I was at Kaiser Permanente, we were able to deliver this at scale. And so what at scale means to me is, I would say it's in all 8 regions. There's over, 4,500 physicians and clinicians using the system. Over 70,000 patients have leveraged the solution since its inception. And I think there's somewhere around 40,000 patients right now that are actively providing data. So that didn't start out that way. It wasn't like we turned the switch and suddenly, everyone's on the system. We stepped back as a group and we brought together our technology team, our clinicians, and we said, okay, what is it we're trying to accomplish here? What do we really want to do? And there were a couple tenets that we came up with that were kind of foundation principles for the program. One was that we want to treat the patient holistically. So yes, we're doing chronic disease management, but a person is not their disease. And so we wanted to really make sure that the solution we implemented was flexible enough to allow our clinicians to create programs specific to that individual if they needed to. So not just diabetes, maybe they have diabetes and hypertension. So I want to monitor this patient with a glucometer and a blood pressure cuff and a scale. So we wanted to have that real flexibility in how we established what were ultimately called programs. The second thing that we talked a lot about is we really want to empower our patients with accurate, timely data so that they're able to modify their own behavior. So the term remote patient monitoring gives the impression that, your clinician is like overseeing everything you're doing. And they're like, oh my God, he ate a donut. We're going to, penalize him. That's not what we wanted to do. That's not the experience we wanted our members and patients to have. And so we made sure, again, that the data was being presented back to the members in a way that allowed them to kind of recognize, oh, what I'm doing now actually is impacting my health in a long-term way. And so, but to break it down, you have to start somewhere. And so I just kind of laid this out in a very kind of simple 3-step process. There's a lot of detail under this that I'm happy to share with anyone at any point, but really you start with select a use case. There are so many that are out there that are going to be of value, but pick one in your organization that maybe you have a large number of patients that have that condition, or you have specific clinicians that are very passionate about delivering remote patient monitoring, because clinician sponsorship matters significantly. You have to have those evangelists out there in the field using the technology. So that may drive which use case you use. And be sure that these are things where you can incorporate this program into the existing workflows. I think that's another thing that gets people a little concerned. It's like this separate program to the side. It doesn't need to be a separate program to the side. It can be something that within your EMR, you trigger a little notification that says, based on the parameters, your patient is eligible for this RPM program. Would you like to sign them up? And so start thinking about, how do you just put this into the natural way you deliver care? And there's lots of groups out there that will help you with physician journeys and patient journeys and all of those things to look at. And then plan for support, because there are absolutely going to be issues. This is technology, and these are humans using technology. And it's relatively simple today compared to how it started out, but there's still going to be times where the data isn't loading, or they forgot their username, or there's different things that happen. You want to make sure you have high touch support so that you can keep that frustration level down. And then from the very beginning, look at what your success criteria is. What are you trying to solve? Are you trying to reduce your operational costs? Are you trying to manage more patients? Are you looking at clinical outcomes? If you establish those criteria up front, then you're able to have, measure against those and then adjust along the way based on the trends that you're seeing. When you go to deploy, early adopters are going to be critical. So early adopters are those people who are willing to withstand any of the bumps and bruises that come along with implementing new technology. Not everyone is capable of doing that. And so again, this is where your clinician sponsors are hugely important. Make sure that they're evangelists, make sure that they're people that are using the system, because it's one thing to have administration say, this is easy to do, versus having somebody that's actually doing it every day. Along with that, provide the basic, quick start guides, training guides that are tailored to your operations, not necessarily about how to click this button or that button. It's, when do I use this technology and what do I do if, those types of things. And then practice your support process. Make sure that your clinicians are using support. Have some of your early users be people that are friendlies that have them exercise support even if they don't need help, because those processes need to be refined over time as well. And then kind of going back to the establishing your criteria, you're going to measure against that. So tracking adoption and utilization is extremely important, but you always want to look at satisfaction as well. So how satisfied are the users with the system? How easy is it to use? Again, these are things that will help you refine the process over the long term. And don't get discouraged. Negative feedback is something you can address. Not getting that feedback is where you might lose the opportunity to improve the program. So definitely ask often, how things are going. And then from a clinical perspective, when you're looking at clinical outcomes, you have to have a certain volume over time. So try to be patient. I know that a lot of people want to know right now, is this working? But I can tell you with KP, the diabetes program, we actually were able to demonstrate a reduction in A1C for those patients that were monitored versus those who were not. We also did satisfaction surveys and found very positive satisfaction. One of the easiest ROI measures we had, though, was around the operations. So the reduction in time for the nurses to actually leverage the system. So that was really key as far as determining the financial benefit of the system. Next slide. So while you're doing this, I honestly don't think we even know the power and the value of all the data you're collecting. I mean, if you think about it, you're now getting to the point where you know this patient on a daily basis. You're starting to understand what is their normal. And the example I always give is I have low blood pressure. So if I was in some sort of program that checked blood pressure on a regular basis, it would eventually turn out that, hey, my normal is relatively low. It's not normal. And so as we continue to collect all of this data, we're able to better personalize the care that we provide and eventually get to the point where we're proactive. So we have all these, mechanisms to run behind the scenes that are like predicting what could happen with this individual based on the data that we've collected. And also, of course, there's the full population perspective as well. So I do think as we move forward, just about everybody, healthy and those with chronic conditions, will be monitored by some device at some point. Doing that monitoring in collaboration with your clinical team just provides a much more holistic perspective of the patient and really improves the ability to provide quality care. So with that, I'm going to turn it back.
Great.
Awesome. Thanks so much, Angie. I really appreciate that. And just to build on what you're saying, at a year ago almost, at the height of the coronavirus scare, when there was the initial surge, the number of visits in the ambulatory care centers declined by 60%. And at the same time, video visits saw 1,000% from the VA increase, and in some cases, many more. So the VA reported they saw video visits go from 10,000 to 120,000 per week. And some systems I know saw an even greater increase. And Fair Health's monthly telehealth tracker actually reported between October 2019 and October 2020 over a 3,000% increase in telehealth claims. So, we have really greatly accelerated the need for this, and that's not going to come as a surprise, but I say all that as a backdrop to what Angie just shared, which is all of the things that need to go in place to enable telehealth. We're doing them. We are doing them right now as an industry. And I think what's really important to note here is that now healthcare consumers, patients, have now experienced this, and it's far more convenient. It's in fact often a lot more convenient for physicians as well. And you can't add convenience into a system, into consumers' lives, and then take it away. So virtual care is definitely something that is here to stay in the future. And if you can go to the next slide, the adoption of video visits has been really great, and it's definitely something that is the right first step for us to take as an industry. However, video visits alone are not enough to provide comprehensive healthcare, because fundamentally doctors need data. So in a traditional model, when you go in for an office visit, you take your weight, your blood pressure, your temperature, your O2 sat, possibly some labs, et cetera. These are all data that the physician or the nurse or the PA has available to review before they even see the patient. And this is really important information. And the challenge is in a traditional video visit, when you just have the video, you're lacking all of those data. And so what we're seeing now is a real need to bring the data into the context of the virtual patient visit. And these data are even more important for people living with chronic disease, which is, as you know, about 6 in 10 US adults are living with one or more chronic diseases. So the data becomes a really important factor in how you can actually provide comprehensive care in a virtual or hybrid mixed model. And so next slide, please. So virtual care programs that are embedded into the clinical workflow and make data entry and other rote tasks very automatic are really the key to scaling these programs, as Angie was saying. And to unlock the power of virtual care, what we need to do is bring in personal health data, labs, other information from patients in their daily lives, which can be used to then escalate concerns and orchestrate workflows that make physicians more efficient. So, Angie was talking about how these data don't necessarily, remote patient monitoring doesn't mean that you have to physically be in front of a screen looking at every single patient and seeing like, what action do I need to take? It's actually the total opposite. A well-designed remote patient monitoring program should be that you have patients enrolled in a program and you've set up escalation points up front so that you know that if you're not hearing things, that's an okay thing. That means the patient is doing what they're supposed to be doing. They're taking their readings are falling within acceptable ranges, and that those data will be super important for you to help review with the patient in your next visit. But if there are concerns that you've, again, set up front, the concerns will be escalated either to the care team or to the physician specifically, however the program is set up. And at that point, it's a necessary medical concern that the physician has signed up for up front. And at that point, we now have something that, that the physicians and other folks at the health system will want to interface with. So historically, virtual care has been implemented sort of inside of the paradigm of the traditional healthcare system. So in other words, just like a patient would reach out and schedule an appointment, a patient reaches out and schedules a video and calls up a video visit in place of an urgent care visit or in place of going into the office. Or maybe the health system wants to engage the patient, so they initiate a virtual chat session instead of the nurse calling the patient up on the phone. But with data-driven virtual care interactions, we can actually flip this and have the interaction be created by the actual data in the real world, and a nurse care manager or a physician can be notified of something that's happening in a daily life of a patient and realize, oh, this is actually something that's important for me to talk about. Whereas the patient might say, I don't want to bother with it. It's not that big of a deal. If the physician might say, actually, that is a big deal. I want to know about that now so that I can talk to you about that now so that it doesn't become something that's more concerning. Another good example of how these solutions can actually be created to help to streamline care. I'll use an example of heart failure, where in a traditional heart failure situation, you're monitoring a patient for with a weight scale, and you're making sure that they're not gaining more than 3 pounds in a 3 to 5 day period. Well, so traditionally, what happens is if the patient, if their weight increases, that sends up an alert. And then, the nurse or somebody at the health system needs to get on the phone with the patient, which can be sometimes hard because the alert might trigger, and then the care manager might get back to the patient, an hour or two later, whenever they next check the thing, their call list. And at that point, the patient might have moved on. They might have, they might not have be around their phone, whatever. They might have, they might be busy. And so they might not answer the phone. Well, what you can do though, in a true automated virtual care setting is you could say, patient steps on the scale. There's patients gain more than 3 pounds. That triggers maybe an AI chatbot at that time that messaged the patient while they're probably still on the scale and said, hey, was this you that stepped on the scale? Do you have swelling in your extremities? Have you been having difficulty breathing? How is your sleeping on a scale of 1 to 10? And ask the questions that maybe a nurse care manager would need to ask at that time. And based on those answers, maybe it wasn't them that stepped on the scale. And so in which case you can probably dismiss the alert or flag it for later review. but maybe it was them, maybe they are having difficulty breathing, they've noticed that they've had some swelling. And at that point, if there's not a nurse available immediately, you can kick off using the automations, you can kick off like a video visit with somebody in network that would be able to take that call and see that patient right then, and offer them to double up on their Lasix or come into the ER, whatever the case may be. So so really that's kind of the highlight of where I see the opportunity of virtual care. And then just to sort of, if you can go to the next slide really quick here, just to sort of highlight very quickly what Angie was saying about the program that we put together when she was at KP. So there's been over 75,000 patients active total in the program over the last few years. There are over 40,000 active today. This is deployed across 7 regions of Epic, and a key to the success is it's deployed inside of the clinical workflow so that there's no different workflows or different sign-ins or logins for the physicians or the nurses or other team members to sign into. But as you can see, there's been really strong clinical results. Hypertension and systolic blood pressure and blood glucose levels for type 2 diabetics and gestational diabetics both come under control within about 45 days in the program. Clinicians find themselves much more effective. About 90% feel like the program saves them time and helps them make better decisions. Patients stick with it. It's very sticky. 75% of the patients are still recording readings twice a day after 90 days in the program. So it's a very highly engaging program, and it's very lightweight. It's very light touch. And the important thing is the physicians feel like it saves them time because they're only hearing about the clinical escalations, about the thing they really want to know about. And that's why it both saves them time and helps them deliver better care. So with that, Jen, I will hand it back over to you, and we can get into the discussion and hopefully demystify the difficulty of implementing virtual care programs.
Great. Well, that was a really good example, I think, Drew, that you just gave there with the last program. Anything that's sticky or patients don't drop out of after a couple of weeks or a month. And I think it's a great example. So we've got several questions. Let's just run through. I know there are a lot of questions coming in through the Q&A right now. So please keep those coming through. We'll put them in the chat box as well. We will get to them. But I do want to talk a little bit about how you do this organizationally. And we have a couple of questions. People always want to know, how do you get buy-in really from your clinical organizations to start doing remote patient monitoring? There's always a little bit of pushback when you're getting started here. And Angie, I'm wondering if you can speak to that a little bit. How did you do that originally? And what do you recommend? What did you learn from that process?
Yeah, it's definitely not easy. I think we implemented Valytic prior to the pandemic. And so there were certainly a lot of naysayers who felt like this was a fad, it was going to be passing. We certainly don't want to invest in that. So there's a couple of things we did. I think I mentioned this before. Having key clinicians that truly believe in the value of remote patient monitoring is really important. So you need to find those who are natural advocates and can be supportive and are willing to exercise the technology. I think that the second thing is that you have to look at it as a journey where you have iterations of improvement. And so instead of saying, okay, we're going to implement this and spend, $5 million or whatever it is, step back and say, okay, let's implement up to $1 million worth. Let's look at our measurements. Let's talk about what's going well, where can we improve? And then we'll talk about adding to that and adding more clinical programs, so build from a foundation that's demonstrated the ability for the organization to actually implement a program and scale from there instead of getting overwhelmed with a 5-year plan. Does that make sense?
Yeah. Drew, you want to add anything to that?
Yeah, absolutely. The biggest thing I would say is, well, actually there's 2 things. One is that one of the biggest thing we still hear is, but physicians don't want or need more data. And there's this big concern about all of the data. And I've said this for years, and I've really seen it true in the successful deployments that we have, is if after you put these programs in place, if a physician or a nurse is complaining about too much data, you've implemented it wrong.
Right.
Because like I said, the point I made in the slides is that if you're setting the program up correctly, it's driven by escalations that the physicians themselves had said they want to know about. And so if you're getting clinical notifications that aren't relevant, then you've put the wrong notifications in place. You really should be highlighting what are the clinical escalations I really need to know about to make sure these patients are managing their conditions effectively. And the second thing I'll say is that we oftentimes see sort of silos of solutions where, you know, cardiology has this particular thing that they want, and endocrinology has this particular thing that they like, and pulmonology has this. And when you start to try to bring these programs up, everyone's kind of fighting for, well, but this is the thing that works for us. And what we've really seen be effective, and I think this is illustrated very well within KP, is an enterprise approach where you can have the same high level program design for all of these. I mean, at the end of the day, it's all personal health data. It's all escalations inside the clinical workflow. It's all visualizations that physicians interact with. There's a lot of commonality spread across these. Now, the devices for endocrinology and cardiology and pulmonology, et cetera, are all different, but the way that you can bring them in from an enterprise perspective can all be the same. And I think that's another really key point to get buy-in across the organization, is to level up and say, how do we actually implement a program that improves the care for all patients in a way that still meets the needs of each specific department? So
actually, you bring up a really good point, because a lot of hospitals are set up that way. So each department, you know, cardiology has their little pet project. So what do you, I mean, knowing that that's how a lot of these programs have emerged right now across the country, how did you get from that to an enterprise program? How did you get the buy-in at that point and say, hey, you know, I mean, is it give up your pet project, or is it that those pet projects can kind of feed into the enterprise?
Yeah, I think from a KP perspective, it's really the latter. So what we did is we brought together clinicians from a broad set of disciplines and specialties and different levels, nurses, physicians, and we talked about what do you want? You know, if you could have anything you wanted, what would it be? And we kind of laid that out. And because they were able to contribute to the process, they may not be the first use case, but they contributed to what that looks like. So they know when their use case comes along, what to expect. And so I think that helped a lot with buy-in. I also want to go back to what Drew said at KP, that whole alerting of physicians with data, that whole concept was a concern at the beginning too. We didn't want all this data, and I can't take any more alerts, that sort of thing. We called it managing by exception. So we should be engaging with patients only on an exception basis when there is a clinical event that a clinician needs to address. And the system that we implemented in partnership with Valytic actually allows for those alerts to be set at the individual level. So you might set them at a program level, saying if they're out of range by X%, then generally I will give an alert to the clinician. But the clinician can go in and say, you know what, no, I want it double that before I get an alert. And so they're able to really control how they treat the patients collectively and individually.
So if they can control when they're alerted, so it sounds like what you're saying is you want them to be coming back to you saying they want more alerts or they want more information. That's a positive sign.
Yeah.
Okay.
Yeah, absolutely. And the other thing I'll say, Jen, around the multiple departments, I mean, this is, you know, fundamentally Valytic is a health data platform, right? We connect with 500 disparate devices and data sources in the ecosystem, from in-home monitoring devices to wearables to health apps on the phone. And so, you know, if there is a particular device or program that cardiology really loves, and is something that you know, Valytic doesn't support, like that's actually a pretty straightforward thing for us to integrate and implement. And it's one of the things for us that our clients typically like, is that if a patient already has a device they're using that works for them, they can use that in the program. If there's a particular device that maybe is high up on a formulary that a particular health plan wants to use, we can, you know, if we probably already support it, but if we don't, we can fairly easily support that device. So we're very agnostic to kind of how these programs are deployed and which devices are utilized.
Can you talk about, Angie, how this fits into the patient record? Do these alerts feed in? How does that work exactly? And you're on Epic, I'm assuming.
Yeah, KP is on Epic. And so again, to the prior discussion, integrating within the existing workflow was a huge imperative. And so within Epic, it actually launches out the remote patient monitoring dashboard. And so you can be within the Epic and select, I want to register this patient for the program, that sort of thing. So that's kind of how the whole registration is very seamless. The data comes back into Epic through flow sheets. And so there's a variety of ways to integrate with EMRs. And I know Drew's worked with other ones besides Epic, but the data does come back in, and that's all passive. So it's not like you're getting flooded with data. You would actually choose to go look at it as a clinician if you wanted to review the history, or go straight into remote patient monitoring, and you can see the whole graphs and charts of the data there.
Okay, so Drew, pick up on that. If you're not Epic, you're not a big shop, how does this work with your medical record?
Yeah, absolutely. So, we do partner with other organizations. And so if we already partner with an EMR, then it's pretty straightforward. And so, we work with and have done deployments with organizations also like Meditech and NextGen and Cerner. But regardless, the way that this should work at a high level is that there are certain things that an EMR is really good at, which are, things like tracking the clinical care inside of a hospital and, tracking things for billing. There are certain things that the clinical record is not great at, which is visualizing time series data over and allowing that to be interacted with in real time. And so what we actually do is we can actually have the data written directly into the EMR via flow sheets, for example. But then we can also visualize the information and provide the panel view inside of, Smart on Fire or other iframe type of situation that works inside of any EHR. And so the benefit of that is, from within the existing, you're already logged in as a physician or nurse or care manager, you can pull up that view, and it's already inside your EMR. It's single sign-on, so it's all behind, all the handshake is happening behind the scenes, and you're able to get a very robust view of the data that you really can't do out of the box with any of the existing clinical data systems.
Okay. We've got so many questions, so if you don't mind, I want to jump into a few of them there. And Drew, this is going to make a lot of sense to you. Can you talk about how Valytic adds values if a provider already has an existing integration engine? So I'm assuming, so you've already got somebody else you're working with to pull in data. Yeah. So how does that work?
Yeah, absolutely. So the existing interface engines, like an InterSystems or a Lineate or something like that, that is a way for our data, for example, discrete blood pressure, glucose, weight, CGM, et cetera, for those discrete values to make their way into the EHR. And so we're happy to interface with those type of engines in order to get the data where they need to go. There's a bigger challenge too, which is the alerts and the escalation points and the visualizations. And that is typically something where there's a separate integration that's needed. It's actually fairly lightweight. They're really fairly simple API endpoint integrations from Valytic's perspective. And generally speaking, it's something that the IT staff at a health system or a plan has available to expose. So we definitely can leverage the interface engines for the discrete data, and then the API endpoints for the visualization and alerts.
I'm going to add to that if you don't mind. I think the other part is that when you're looking at those integration engines, you might be thinking, oh, I can just code to all these devices. It's actually not that simple. And that was another reason why KP partnered with Valytic, because what they do is they can bring in information from various vendors, different devices that bring in similar data, and they normalize it. So from a clinician's perspective, I don't know what device necessarily was used. I just know that the data is accurate and I'm able to leverage it. So it's not as simple as, just hooking up an interface engine. There's so many devices out there. And as we move towards more BYOD, that's going to be really complicated to keep up with.
Yeah, totally. Thanks, Angie. Not to mention another big thing we hear, so obviously there's which blood pressure monitors at Omron or Withings or Welch Allyn or whatever the case may be. So we definitely standardize that. But the other big thing is, every new device that you bring in is a new security endpoint or to be reviewed, and something else that your security team is going to want to take a big look at. And so with Valytic, there's one security audit. You know, we're ISO 27001 in high trust. Like, we go through that process, and then when you bring on a new data point, it's kind of coming through our like cleansed system, and so there's no more IT security review on that front.
Okay, great. Can you talk about, Angie, a little bit about how you get patients to start using these programs? And I know you've talked a little bit about having kind of physician champions, but how does this work on the patient side?
Yeah, so for KP, they elected to provide the devices because these were, you know, chronic conditions that they managed anyway. And so they wanted to make sure that the patients were using devices that were approved. And so there's a couple ways of doing it. You can, you know, have the conversation from a clinician with the patient saying, you know what, I think you could benefit from this. Let me ship you the device. And the whole logistics around that are not as simple as it would seem, but there are logistics in place at KP where they can track that this was ordered and shipped. And then the support team actually is the ones that like helps the patient get their device set up. So it comes in the mail, you open it up just like you would maybe, you know, when your new cable box comes in or something like that, and you set it up. Now, it's not that simple for everybody. So older users or less tech savvy users may have a little trouble. So you always have a number there for them to call. And those people, you know, the support staff will talk them through exactly how to set up the device. Once they're set up and they've allowed the data to be transmitted to the care organization, it becomes very passive. So you just really have to get over that little hump. Then it's a matter of just monitoring on a regular basis, because then the data just continuously feeds in. There's
Right.
also support tools that if for some reason a patient's been feeding in data and all of a sudden stops, that the support team has a dashboard that they can say, okay, I wonder why they stopped. Let me reach out to them and see what's going on. So it's that's kind of the patient process, if that makes sense.
Okay.
Yeah, my favorite thing about that patient experience, and I do want to highlight something Angie kind of glossed over, which is this is patient authorized data. So it's like the patient's enrolled in the program, but they're not actually in the program until they actually consent to the program and consent to the data sharing for each device.
Let's
which
just
is
highlight that for everybody.
Yeah, super want to highlight that right now with all of the
Consent model
concerns.
for all the privacy questions. Yeah, the patient has to
Exactly.
consent. Yeah.
So once the patient consents, but my favorite thing about this program is it is intentionally light touch, and I think that's actually one of the things that's made it so effective, because the patients, once they're enrolled in the program, they'll hear from the program automatically. If they don't record a reading, it'll say, hey, you forgot to record a reading today, make sure you do that. If they're recording a reading at least once a day, they're good to go. Like, that's the only thing that, and they're told that up front, like, hey, we're asking you to record a reading, you know, once or twice a day. If you don't record a reading at least once a day, we're going to let you know. And if you don't record a reading in a week, we're going to actually reach out and find out what's going on. So that there's like that built-in accountability. But other than that, there's not like an ongoing encouragement or gamification. It's basically like, just do this thing and live your life, and then we'll reach out if there's any problems. And patients really like that aspect of it, of like, wow, I can just kind of live my life, and this is just sort of in the background.
So, I mean, one question we've gotten is, you know, and you're from a large organization, Angie. So, you know, you had really an option in terms of building this program internally versus outsourcing it. And that's question, I'm assuming there are a lot of smaller or medium-sized groups that are trying to struggle with this. Do I do this myself, or what are your thoughts on that, Drew?
Yeah, absolutely. I mean, I will say that it is very difficult to do this on your own. And Angie can speak to this directly, because KP went to try to do this on their own, and Angie reached out and said, let me tell you what we're trying to do. Can you help here? I'll let you tell that story better than I can, Angie. But I would say, you know, in general, what we see is that organizations who say, okay, I think I can bring in the data and build something on my own with my existing EHR capabilities, et cetera. What they find is that they're not working with a tool that is purpose built for the solution. So they can kind of cobble something together that might work in a very small, isolated patient population, but it doesn't scale in a way that's easy for physicians to use, nurses to use, and most importantly for patients to use. The graphs aren't robust enough. The alerts aren't there in the way you need. The data reporting is not helpful. And so, I would highly encourage at least a strong look at an organization like Valytic, where we have done these implementations and installs at scale and really understand and can bring best practices to bear around how to do it. And Angie, I don't know if you have anything to add, but
yeah, no, I think
we
even
want to hear the story, Angie.
Yeah, no, that was actually on the floor of the ATA one year where Drew and I met and started walking around talking about what KP was doing. And he's right, you can get down the path from a development perspective where you're basically investing in technology. You're not investing in changing the way the organization delivers care. And so I believe that healthcare organizations should really focus on the operations and how they deliver care and improving their overall quality, and outsource the technology and the distribution logistics and even the support aspect. I would probably, and to some extent, that is what KP did. They used Valytic as the solution from a technology perspective. They used Trapalo for device distribution. The support is in-house, but and there's some custom development, but for the most part, it's pretty outsourced, and the focus is on the operational side.
So Drew, I mean, just as a follow-up to that question, so your recommendation in terms of a small group or a solo practitioner rolling out an RPM program, you would say, go outsource it? Definitely.
I mean, so yeah, I mean, it's challenging, but like I would say that's probably for the best for any, and there are solutions for all sizes and scales.
Okay.
And I'll say we have some partnerships with smaller EMR vendors, or I shouldn't say small, I should say large EMR vendors that target small to medium size physician practices that can help roll out these programs too. And so there's a lot of really great opportunities in the market for those type of programs. But yeah, absolutely. And to the extent that anyone who's here is interested, I mean, Valytic is all about helping to get more people connected with personal health data in the ecosystem, period. And so if you reach out, like we will absolutely help you. If Valytic's not the right solution, we'll help you find a solution that is right for your size organization, because it's just too important right now for us to really advance virtual care for patients so that they can remain engaged in the healthcare system and not sort of say they're never going to get it and like figure out some other path. And
we're putting a little link out here. So if you do want more information from Drew, check yes on the poll that you just got. There's no pressure here. You can ignore it or press no, but if you do want more information, go ahead and press that and Drew will get back to you with some more specifics. We just want to make sure everybody's connected here. So we've gotten a lot of questions about reimbursement. How does this work now during the pandemic? We know that certain things have been waived. We've heard about this for telehealth and virtual care, but what's it mean for remote patient monitoring? Angie, do you want to try to tackle that first?
Drew probably actually knows this topic a little better than I do, just because of the structure of KP, so I'm going to flip it to him.
Okay, Drew.
100%. Yeah. So I will be very candid and say I was initially a couple of years ago very excited about the RPM codes from CMS. I remain intrigued, but I am more bearish on them today than I have been previously. And the reason is that, without getting too into details, is that the way that CMS has implemented the RPM codes, especially for 2021, is that 99457 and 99458, which is the reimbursement for actually reviewing data for 20 minutes at a time, now also includes a telephonic visit component. And so if you're going to be getting on the phone with the patient anyway, and you're going to be having multiple people review the data, a level 2 office visit gets you twice the reimbursement for half the time. So you probably might as well do that. But there are other opportunities still to leverage the codes. So for example, 99453 and 99454, which is the setup, the one-time setup fee, and then 99454 is an annual, a monthly fee for basically having the devices in patients' hands and having data delivered from those devices. That is something that's pretty interesting and can actually cover the cost of the device logistics, devices in patients' hands, the data sharing platform, like what we're talking about here. And then you have now coverage for patients with 99454, and you can have a solution like Valytic that's able to put the devices in patients' hands, and then operationally you can actually just keep in a fee-for-service world, you can actually just keep keep your level 2 visits even virtual, given the current environment, and actually probably be reimbursed more. The other challenge that I have with the RPM codes is the copay piece, which is waived during the public health emergency. But when that comes back, if you're looking at stacking 99454, 99457, and 99458, which is an additional 20 minutes of review, each one of those comes with a copay. So you could actually unintentionally be saddling a patient with, 40 to 60 bucks of copays in a month that they didn't necessarily know they were signing up for and aren't going to be super intrigued about. So that's the other thing that I don't really particularly love about the way the codes are set up today. But I do think there's opportunity. What I will say is this, though, not all is lost. There's a couple of opportunities in a fee-for-service health system to actually find some value today in these programs. So one example, it's very direct, is heart failure. That's something where you're improving patient care, but you're also reducing readmissions, which is a huge challenge. And that's something that we can directly deploy today that immediately hits the bottom line. There's also things like, hypertension for HEDIS scoring is a really big challenge to keep those numbers. And, our hypertension numbers for patients in our program are stellar. If you saw on my slide, within 45 days, systolic blood pressure dropped from stage 2 hypertension to normal range for those patients. So it's something, there are actual both quality scores and readmissions that we can help prevent immediately today that hit the bottom line that aren't necessarily tied to RPM billing.
So it sounds like there have been some changes in terms of the pandemic. So the co-pays are waived right now because of the pandemic. So those could, as with a lot of these reimbursements tied to the pandemic, they could potentially go away and patients could start getting, we hope not, we're working on it. But so there have been some changes because of the pandemic, because that was a question from one or two different folks here. So I just want to
the copays being waived is the big one. That's the one that right now there's a huge benefit. But the second that the public health emergency goes away, at least as it's written today, the copays will come back. And so that's just something that, and the other thing is too, sorry to just say one more thing.
No, go ahead, this is important.
Yeah, the other thing is too, is that's just for Medicare patients, right? So for patients who are with any other commercial insurer or any, whether it's a Blues plan or one of the big national plans, they have different levels of reimbursement for these RPM codes. And they're not always published, and sometimes they're actually negotiated more on a per plan basis. So it might not even be applied to the entire population. So that's another challenge too, is what is the level of reimbursement and what would the copay be for those patients for each of those plans. So that's the other confusing part, is that there's just not a lot of standardization there.
Actually more confusing here, because can you talk about in a non-payer environment? So are there places where we're just billing this to patients, or providers are absorbing the cost, or how else have you seen this done?
Yeah, I mean, actually the way I've seen it done the most successfully so far is in groups that look the most like KP. So this is ACO groups, the MSSP programs, MCOs, anytime that there's an existing population that's at risk. I mean, I was gonna say the good thing about the US. The sad reality about the US, right, is that a lot of people have diabetes and hypertension. And so if you have, several 100,000 at-risk patients in your health system, you're going to have thousands or tens of thousands of patients who are really ready right now for a program like this. And you can actually dramatically improve how you deliver care to those individuals and have the savings flow through, because you're actually providing better care and reducing hospital visits and hospitalizations and other utilization. Okay.
We have a question here, and several questions. I don't know if you know, but for certain diseases like Parkinson's, what do you see as the reimbursement status now using remote patient monitoring for wearables? Any thoughts? I'm not sure specifically why the Parkinson's.
Yeah.
We have a few questions on Parkinson's.
So Parkinson's is very interesting. In terms of reimbursement right now, I don't believe that there is reimbursement available because it's only available for FDA listed Class 2 devices.
Okay.
And currently the wearables are under enforcement discretion. And so they don't actually fall under, they're considered a wellness device. And so there's not an opportunity there that I'm aware of. But certainly if anyone on the call has anything and wants to put it in the chat, like I'm super open like that, it would be a very interesting use case for sure.
Yeah. So Angie, can you talk about kind of the staffing in terms of once this escalated data starts coming in, was that assigned to a specific person? Did the whole workflow kind of absorb that? How does that work? Because there's questions about, this looks like it would require an increase in staffing.
I think it depends on where you're at from a starting point. So KP had an existing, very well-staffed, large care management program. So actually it allowed for them to care for more patients. So each clinician had a larger panel because they spent less time. So the way it worked before RPM is they would get on the phone with the patient at regularly scheduled intervals, whether or not it was a clinically significant time or not, it didn't matter because it was scheduled. And then ask, what were your readings, and write that down, which is obviously open to all kinds of errors. And it took a lot of time. And so now that they're getting the data in passively, they can actually just look at their panel and figure out who do they need to contact and who do they need to work with. And so for them, it expanded their capacity. They chose not to reduce staff, they could have, but it really expanded their capacity. So I think if you're an organization that has no care management at this point, there might be a slight uptick in your staffing needs, but that should be offset in other ways. But if there's already an existing one, though, again, you would have the opportunity to reduce staff or potentially manage more patients.
Yeah, and I think that's such an important point, Angie, because I think one of the things that is outside of the purview of this particular discussion, but certainly in line with something that's very relevant for our industry and our society, is that healthcare workers have been just running flat out for a year now. And we're seeing early retirements, we're seeing folks opt out, we're seeing people I've seen on med Twitter and stuff, physicians saying, look, I'm sticking through this through COVID, but I am done after that. And so I think that, we already had a stressed, stretched healthcare system, and now we have even more stressed, stretched healthcare workers. Mm-hmm. And I think we're going to see even more healthcare workers take leave or early retirement, which is going to exacerbate the problem of the decrease a workforce that was already not at full capacity. And so programs like this, to Angie's point, when you can take more patients in a program or more patients under management because you're able to manage by exception and still know what's going on, I think that's really incredibly important for the future as we look at how do we manage an increasing patient load with a decreasing number of physicians and other clinical team members.
Are the peripherals for these at the patient side, do you have to have a smartphone?
So I will say in general, often. So in KP's program, they do work with patients who have their own smartphone. We work with other programs with some clients where a tablet is provided and devices are sort of prepared and kitted and shipped with the tablet. And so the patient receives that and they can just use that tablet. So there's a variety of operating models. It really depends on the payment structure and what the health system is willing to take on. And it also depends on the populations that they're trying to serve. So if it's, sort of the early seniors, younger seniors, and the more general population, you can probably rely on them having a cell phone, generally speaking. If it's the older seniors who are going to be much less tech savvy. My 90-year-old grandma is a great example. My grandfather bought her an iPhone a couple of years ago and she said, return it to the store, I don't want that. She would be one that would need a tablet.
Well, we've got about a minute and a half left. So I'd love to give each of you just kind of 30 seconds or so to give some words of advice to folks who are interested in taking this journey and just getting started. Angie, you want to go first?
Yeah, thank you. I really appreciate that. So it's been great to be here. I'm very interested to get the feedback from this program. And, you know, the advice I have is really to start simple, and to be willing to go through a few bumps and bruises along the way. That's okay. That's normal. Learn from that and continue to iterate on your program, and it will naturally scale. So this is where things are headed. You can kind of get on board and really start doing it, or you're probably going to be a little bit left behind.
Yeah, I totally agree with that, Angie. And just to put one additional point on what you just said is that, you know, in the healthcare system that we're in, physicians don't become physicians and leaders don't become leaders because they say yes and they applaud things. Typically it's because they like to dissent and say what's wrong with the situation. And so we actually see a lot of these programs get stifled when they go to committee or when they go to leadership, because there's someone in the room who's saying, but what about this gotcha? And everyone's like, that's a good point. And then it stalls out because, and loses all momentum. And so I would say, you know, try to really work through those challenges and say, okay, hear that point. Let's do it anyway and keep that in mind and see if that's something that surfaces. And really keep moving on and keep the momentum, because as Angie said, this is here to stay. It's gonna happen, and it's either gonna happen from health systems, or it's gonna happen from payers, or it's gonna happen from the newcomers to the market, like, you know, the Village MDs and the CVSs and the Walgreens and and the Amwells and Teledocs of the world, right? Like that's really who's gonna do it if the health system doesn't figure it out.
So really push through and persevere if you want to survive. Yeah, this is fantastic. And I want to thank both of our speakers, Angie and Drew, today. We got through about half of the questions. Thank you for joining us today. And I know that Drew and Angie would be very interested in reaching out to folks and following up. If I know there were several folks that wanted some more specific information. So thank you for joining us today. Everybody have a wonderful afternoon, and we'll see you next time.
Thanks, Jen. Thanks, Angie.
Thank you.